improve this. All right, so 2 anemias down. A 60-year-old patient comes in, they have hypothyroidism and they're on thyroid replacement, and they're now complaining because they have paresthesias, fatigue, and you do some blood work and they have a macrocytic anemia. So which of the following should be suspected? Pernicious anemia, anemia of chronic disease, folate deficiency, or iron deficiency? Very good. Very, very good. So what was the clue for PA over folate? The paresthesias. Yeah. Remember that you don't get neurological abnormalities usually with folate. Okay. So that was your clue. And remember, anemia of chronic disease is usually normochromic, normocytic, not macrocytic. So this is most likely PA. Pernicious anemia, B12 deficiency. You can become B12 deficient because of dietary inadequacies or abnormalities in the bowel. Also, you can become B12 deficient, and most commonly because of autoimmune process. The autoimmune production of antiparietal cell antibodies, intrinsic factor antibodies, blocks the absorption of B12 in the gut. You see this also in association with other autoimmune phenomena, so things like the hyperthyroidism, any of the other autoimmune diseases can be associated with B12. And remember that B12 is the one that gives you the neurological deficit, so that's the clue there that that's what you're looking at. Folate deficiency, usually secondary to dietary deficiencies. Patients like alcoholics, drug addicts that have inadequate diets, malabsorption, again, things like Crohn's and some of the inflammatory bowel disorders. Chronic hemolysis, so patients with sickle cell, beta thal, alpha thal, if they're not on replacement, may become folate deficient. And then patients that are pregnant, so not only iron deficiency in pregnancy as well, but folate deficiency as well. Clues that you're looking at somebody with a B12 or a folate deficiency would be macrocytes, which are big red cells, macroovalocytes, and we'll see some picture of those. Again, an elevated RDW. Usually with B12 deficiency and folate deficiency also, you see not only an anemia, but you see kind of a mild pancytopenia. So you're going to see some effect on your white blood cell count as well as your platelet count. So they will both be lowered as well. And then, of course, there's the classic hypersegmentation that everybody knows about, but is a really good clue. And then a decreased reticulocyte count, because again, you don't have what you need to make the cells, so the retic count will be low. And these are macroovalocytes, and you can kind of see how large they are, kind of see that oval picture to them. This is a lymphocyte. A normal red cell would be about the same size as a lymphocyte nucleus, so it ought to be about the size of that. And so you can see how large that is in comparison. And that oval shape as well. So that's a macroovalocyte, B12 and folate, and that is hypersegmented neutrophil. How many lobes does it have? 1, 2, 3, 4, 5. That one has 6 lobes, very, very pretty 6 lobes. How many do you have to be hypersegmented? I'm hearing 5. Anybody agree, disagree? Actually, any 6-lobe poly makes you hypersegmented. So just one 6-lobe or 5% 5 lobes will make you hypersegmented. So you have to kind of look through and see. So you have to see a lot of 5 lobes or any one 6-lobe. And remember, technically to be a lobe, you have to have a little string between the lobes. So it can't just have a little indentation. It actually has to have a little string. So this is very pretty for 6. Occasionally I fudge and call 6 when they're not quite so pretty. All right, so B12 and folate, how do you diagnose it? Pretty easy, huh? You just check those levels. Ought to make sense. So for B12 deficiency, you would expect the B12 level to be low. For folate deficiency, you would expect the folate level to be low. And remember that occasionally people have subacute B12 and folate. It's usually subacute B12. So somebody that you really suspect may be B12 deficient from whatever signs or symptoms that they have, but their B12 level is low or it's low normal and you're thinking they're subacute, you can check a couple of other levels. And you need to know these as well: an MMA, a methylmalonic acid, and a homocysteine. For an MMA, it will be elevated in B12. And then for the homocysteine level, it will be elevated in both B12 and folate. So both of those levels in B12 deficiency are elevated, MMA and homocysteine. And then the homocysteine differentiates because it's the only one abnormal in folate deficiency. Okay? So those are some tests that you can do if you really suspect that you're looking at B12 deficiency. Another test that you can do is a Schilling's test. How many people have heard of a Schilling's test? Yes, my job is done. How many people have seen a Schilling's test? That's what I figured. That's what I figured. You know, and they love this test on the boards, or at least they have in the past. It's kind of fallen off the radar a little bit because you can't get the isotope anymore. It's very difficult to locate and get, so not many places do this test anymore. Plus the fact that we can now measure antibody levels and the MMA and the homocysteine. We don't really need to do this test as much. But they still like this test on the boards because it's a good old standard. So know a little bit about this, okay? And so do you know how to do a Schilling's test? You've all heard of it. Well, that's at least a start. So what you do is you actually give a dose of IM B12. So you want to saturate all your binding sites so that you're not worried about the next dose that you give being taken up by the binding sites. So you give a dose of IM B12, and then you follow that with labeled B12 that's given orally. And then you're just going to measure what happens to that oral B12 that's labeled. It's radioactively labeled, and you're just going to measure where it goes. And you're going to look at a 24-hour urine sample and measure how much excretion you have in the urine. And if you have a very low level, then you're not getting absorption, okay, because you know it didn't go in the binding sites. You've already saturated those. So if it doesn't come out in the urine, it didn't get absorbed. So you're looking at 24-hour urine absorption. And then you can go a second level further on your Schilling's test, and you can actually give that label B12, and you can add intrinsic factor to it. And if you do that and then you see absorption, then you know the intrinsic factor fixed the deficit, and then that's your problem, is that you didn't have intrinsic factor. If it doesn't fix, then you probably got bacterial overgrowth in your small bowel, and you can't absorb even with intrinsic factor. So a good test, but like I say, kind of fallen by the wayside. It's very difficult to do. You've got to have a lab that knows how to do it, and you've got to be able to actually get that radio-labeled B12, which is hard to find these days. Other tests that you can do for B12 and folate deficiency would be parietal cell antibody levels and intrinsic factor antibody levels, and they just kind of help cinch that diagnosis of pernicious anemia. So what do you do once you diagnose it? Well, as always, you got to treat it. So you want to treat, you want to replace B12 if you're B12 deficient. So you're going to do that with IM injections. Usually you have to do this replacement lifelong, because once they make those antibodies, they're going to continue to make them, or once they have a deficit or an abnormality in the small bowel, you don't really fix that. So you're going to need to do lifelong replacement. Lots of different ways to do it. This is the schedule that I use. I do it daily for a week, weekly for a month, and monthly forever. And usually an IM injection. There are lots of places in Europe that actually use oral replacement. Even for this, they just give really, really big doses of oral to try to overcome the deficit. But usually in the United States, what we do is IM injection. And then folate you can replace just orally. Usually 1 milligram a day is enough.